you. Next, we have Dr. Kiran Gopalakrishnan. He is also a reputed glaucoma specialist from Precise Trivandrum, and he will be telling us what to do, which is better with a lead fading bleb, tube, or trab. Go ahead, Kiran.
So, in a late fail bleb, actually there are better options than either repeat tube or trab. We can do other procedures also, but for the purpose of this discussion, we will look at either of these two procedures. So, irrespective of the cause of failure of blebs, all of them have one common feature, and that is fibrosis. So, even if you go back early in 1983, where we could look at the histological samples of functioning blebs and failed blebs, you see the functional blebs are characterized by the presence of microcystic spaces, and the failed blebs are characterized by the presence of large numbers of fibroblasts. So we have tried numerous agents to combat this fibrosis and increase the success rate of trabs, and we have succeeded to some extent with the use of mitomycin and 5-fluorouracil. But irrespective of the use of mitomycin, a significant percentage of blebs fail in the long term. Depending on the time frame and the studies you look at it, the failure rate is about 50% at about 10 years. And if you look at some really long-term studies at 14 and 15 years, it will show failure rates even as high as 75%. So in your practice, you will definitely face failed blebs. So should we now go in for a repeat trab or tube? Whenever we evaluate these procedures, we evaluate them broadly in two baskets. One is in success or failure rates, and other is in terms of complications. But this is a very broad basket. Within the success rates, you will also find variations in complete versus qualified success. And something we don't usually give a lot of importance to is the morbidity associated with each of these two procedures. Because by the time you are dealing with a failed trab, morbidity is the last thing you think about. Now with complications, you not only want to consider early and late complications, but also complications which are minor versus more serious ones that can really affect the patient's vision. Now, if you only relied on the data of the TVT, which is the level 1 high quality evidence we had addressing the same question of whether we should do a repeat trab or a tube in cases of failed trabs, it's an absolute slam dunk decision in favor of tubes, because not only were the success rates higher for tubes at 5 years, the early postoperative complications were higher in the trab group. But we also need to keep in mind that the complication was dominated by two things: wound leaks, which is eminently preventable through a watertight conjunctival closure mechanism, and hyphema, which is very much self-limiting. Now, the late postoperative complications were similar between the two procedures, and the serious complications were also similar, though there was a difference in the kind of complications you had between the two groups, with trabs having more hypotony related complications and the tubes having more implant related complications. Now, TVT is level 1 high quality evidence, but the TVT patients had a baseline IOP of 25 plus or minus 5. We will have patients with much higher ranges of IOP in our practice. 81% of the patients had primary open angle glaucoma. Would it be different between the two procedures if you had a higher percentage of angle closure glaucomas as we have? All the patients in TVT had a barbell implantation and 0.4 milligram per ml of mitomycin C. We will use a combination of both valved and non-valved devices and generally use lower concentrations of mitomycin C. And of course, TVT's data from the most accomplished surgeons in the real world. Patients will have to deal with surgeons like me as well. So let's look at some real world data. So this is a study from the US Medicare beneficiaries. They have this wonderful data, and they classified these patients, and we'll omit the first group of primary trab because it's not relevant to our discussion here. We'll compare the trabeculectomy with scarring and the tubes. So here in the real world, the tube patients had more of adverse outcomes compared to repeat trabs. So even in, not only in the less severe adverse outcomes, even the more severe adverse outcomes, those the tubes had greater incidences of endophthalmitis, corneal edema, and more incidences of blindness and low vision, though they had lower reoperation rate. So the real world data is a little different from the RCTs. Another real world data is from the IRIS, the Intelligent Research Insight, which is a registry that is being compiled since a decade now by the American Academy in collaboration with the other national ophthalmic societies of the world. and they have a TVT cohort. And again, if you compare the results, the advantage that tubes had over trabs in the original RCT, in the TVT RCT, is not replicated here. Both had similar outcomes. But in fact, the complete success rate was higher in the TVT cohort of the IRIS registry at about 53% compared with 34% at complete success rates. What about morbidity? What about the recovery of visual acuity, the recovery of pain, and all these things that make a difference to the patient? So again, this is a study that looked at this very same question. We are omitting the cataract patients because they have a huge improvement in everything. So with visual acuity, again, you had a slower acuity recovery with tube surgery compared to trab surgery. If you look at the pain scores, again, tube patients had a slower pain recovery compared to trabs. Patients generally had to take more time to return to work, to come back to drive, and all these with respect to tubes compared to trabs, which makes sense because generally tube surgery is involved with a much greater amount of dissection. So if you look at both real world data and the RCT together, tubes and retrabs are not hugely different. It does not mean that tubes have a huge advantage over retrabs. But what are the factors that might help us choose one over the other? In general, when you have to do a retrab, greater the fibrotic potential of the eye, prefer tubes. So one way of looking at it is the time to failure. Say you have a trab that has failed over 6 months to 1 year compared to a trab that has failed over 10 to 15 years. Obviously, they will behave differently in a retrab. So the faster the failure of your primary trabs, you can prefer tubes. And also look at what was the original indication for the trab. The original trab was done for a uveitic eye or an NVG, or if an eye had had multiple surgeries, you prefer tubes. So look at this example. This is a previous trab eye, but you also see the silicon oil bubbles there, the pseudophakic eye. This is a traumatic eye which has undergone multiple surgeries, and with the level of inflammation, a repeat trab is definitely going to fail in this patient, and subsequently this patient did well with a tube surgery. Generally, if you have a lower baseline IOP and you want the patients to be brought down to a very low target IOP, you prefer trabs. This is from the TVT IRIS data. You found that the tubes perform poorer in lower baseline IOPs. When the IOP is greater than 26 baseline, they tend to perform much better. Even the original TVT study showed something similar. When the baseline IOP was high at more than 25, you can see the huge difference between the tube and the trab, with tube being much more successful. But with IOPs less than 21 or between 21 to 25, the difference between the tubes and trabs is kind of diminished. Whenever you have a greater risk of corneal decompensation, you prefer trabs. It doesn't mean that a patient needs to have a corneal pathology. You have a phakic patient or an angle closure glaucoma, very difficult to put in a tube in the sulcus in phakic patients. In such patients, you can consider trab as an option, because we know very well, even from the TVT data, that corneal edema following either of these two procedures is much bigger with the tube surgery. If you look at it in another way, if you look at the percentage of patients who underwent an endothelial transplant, again you can see that trab is nowhere in the picture. It's the tubes that causes maximum endothelial damage. So eventually, it's not just the TVT data where tubes, when you have a failed trab, immediately jump in for a tube. It's not that. The choice between either of these procedures is certainly more nuanced and multifactorial, and not a slam dunk win for tubes. Thank you.
Thank you, Kiran. As usual, well researched and well presented.